Hi guys. Look at all you early birds. All right. If we want to do something fun while we're waiting a few more minutes to officially start, we could maybe put in the chat. I know there's like just a few of us in here, but if you want to, you can put maybe where you're from and what you do. So like I'll say I'm a pelvic floor PT. I live in Dallas, Texas. I know we got some people from across the pond, which is pretty cool. Oh, yay! I'm so excited to have everyone. Give everyone a couple more minutes. X-Fizz, very cool. Denver, Monica, Denver. Have you met Amelia yet? Amelia is with Genesis. She just moved there a few months ago. Let's see. Tucson. I just went to Tucson for the first time last year. Very cool. Anyone who's just getting on, if you want to, we're just saying our name. No, we're not saying our name. We're saying, we're saying where we live and what we do. Oh, yay, Monica. Hi, Brooke. Very cool. Okay, where are our peeps from like Europe? I know we got some in here. Let's see. Maybe I missed some. Maybe they're all sleeping because it's late over there. Okay, about one more minute, guys, and I think people will probably be popping in as we get started. But one more time, what we're doing is in the chat. If you want to, you can just put in there where you live or where you're from and what you do. Just it's kind of fun to see where everyone's coming from. I'm gonna go ahead and start sharing my screen. Oh, yes, Millie. You're gonna love it. You're gonna love it. Yes, there's a UK. Oh, and a Canada. Woo! Okay, let me start sharing my screen here. See if technology is going to be nice to me. Okay. 4 o'clock. All right. Someone tell me in the chat, you guys can see my Canva screen? I can't see y'all, so someone just, okay. Oh, thanks, Angela. Hi. Okay. All right, guys. So we're gonna get started here real shortly. Hi, Audra. Okay, I'm gonna have to turn off the chat because I'm gonna be seeing all, not turn it off, but I'm gonna have to get off my screen because I'm gonna be seeing all you people that I know and freaking out and saying hi back. So, good news is that one of our Genesis interns, Madison, is here and she's going to be manning the chat, which is so lovely of her. So if you do have like logistical questions or if you're like, oh my gosh, like I can't actually see your screen, then please put it in the chat and Madison will let me know or we'll be able to figure it out. Maybe, hopefully, we'll see if we can figure it out. Okay. All right. Well, we can get started. It's 4:01. People can just keep jumping in. If you recently came in and didn't hear what we were doing in the chat, we're just putting where you're from or where you live and what you do. All right. So thank you guys so much for coming. This is literally my first live workshop I've ever done in my life. And I'm like, what the heck? There's so many of you guys that are interested in this, which is really exciting. And this is my favorite topic is the foot and pelvic floor. connection. So naturally, that's what I want to teach you guys on today. I hope you guys can stay to the end because we're going to keep you guys muted. Again, use the chat if you have logistics questions, but we're going to keep you all muted just to avoid any accidental disruptions. And at the very end, there's going to be time for questions and answers. So I'm really excited. Um, Again, thank you guys so much for being here. I hope you guys learn a lot, and I hope you guys get as excited as I am whenever I think about the foot and what it means for our pelvic floor patients, and how it really, really could be the missing link to everything of pelvic floor dysfunction, leaking, prolapse, SI joint pain, pubic symphysis pain in pregnancy, chronic low back pain, all these things. And I'm excited to kind of share my thought process on that and my kind of journey learning about the foot and how it's completely transformed the way I practice. So without further ado, let's do it. Okay, so a little bit about me, because I'm guessing not all of you guys know who I am. My name is Becky. I am a doctor of physical therapy. That's my sweet, precious family over there. My husband, Philip, we're adorable. We are high school sweethearts. I've been with him since I was 15. And those are our sweet, precious children, Duke and Ava. They're second grade and kinder. And that's just my whole little world over there. My favorite people. And then on the other side of the screen, you can see my team. So like I said, I'm a pelvic floor physical therapist, and I am also the founder and owner and CEO, I guess you can call me, of Genesis PT and Wellness. We are a pelvic floor therapy practice. We have a few locations spanning across DFW, Texas. That's Dallas, Fort Worth for people. I realize not everyone knows what DFW means when I say it. So it's Dallas, Fort Worth. It's a big, huge metroplex in North Texas. We also recently opened out-of-state branch in Denver, Colorado. We sent our girl Amelia, I'm gonna hover over her head. This is Amelia right here. She moved to Denver with her husband, and about a year before she moved, she brought it up to me and my now co-owner, Corey, and was like, we're not going to be in DFW forever, but we love Genesis, and I really would like to talk about what it might look like to take it with me to Denver. So we spent about a year planning that, and that was wild because you would think that we got it perfectly right with a year of planning. But I'm telling you right now, opening a business across state lines has been wild. But she's doing great. So I just thought that was a really cool story. So that's my team, that's my family, and a little bit about me for those of you who don't know me or haven't met me yet. But yeah, thanks for being here. Okay, so let me explain kind of what I want to cover with you guys today, give you kind of a little bit of the lay of the land. Love this little skeleton, girly. I don't know. That's just felt like the vibe. So today I, of course, am going to talk about the foot a lot, and it's going to be so great. I do want to also cover kind of an overview of like what I would consider kind of my method or my framework, because the foot is one piece of that, and it's a very important piece, and it's a very interesting piece, but I just kind of want to give you an overview of how the foot plays into the whole thing as well, because we want to be holistic providers and PTs and OTs and coaches, right? I always say, like, yeah, the foot very well could be the missing link and probably is a thing that we're missing in a lot of our patients and clients, but it's probably also not the only thing. And so we want to be aware of what the foot's doing or not doing and how that's contributing to the pelvic floor, but we also want to be aware of what it means for the kinetic chain and what potentially could be coming from the top down to the pelvic floor and how that's affecting it and impacting its function and everything like that. So I'll kind of give you a brief overview of everything else, just so you don't think I'm only the foot girl, even though I love the foot. But we will dive deep, deep, deep into why the foot is so integral for pelvic floor function. There is a direct biomechanical correlation. There's also some like anatomical connections. I'm not going to go as much into those. I know if any of you guys saw that form I sent out asking like, what do you really want to learn? There's a couple of you that were like, I want to know the anatomy connections, like the fascial trains and stuff like that. In this workshop, I won't get into that. I do talk about that in my full course if you're interested in that. But we're going to talk mainly biomechanics today, of like how the biomechanics of the foot is going to change what's happening at the pelvic floor. And that's going to really help you guys understand when I have leaking patients or patients with prolapse or heaviness, pressure, things like that, how might the foot and what it's, doing or not doing, how might that be impacting the leaking and the prolapse symptoms? So we're going to do a ton on that. We're going to talk about pronation, the ever famous question, is it bad? Do we, some of you guys might wonder about orthotics sometimes. Do I need to put my flat foot clients in orthotics and things like that? Or basically pronation has been made a villain, I think. Everyone says pronation is bad. We need to not allow it to happen. And we're gonna kind of reframe that today, and give you a new way of thinking about that, because we do need pronation. And I'm finding myself wanting to I want to tell you everything right now, and I promise I'm gonna get to it. So I got to keep myself on track, but we'll get to that. And then I'm going to give you some manual therapy, some assessment, some exercise stuff that you can kind of take today and implement with your people tomorrow. And then, like I said, we're going to do just kind of put it all together with the big picture of, yes, we're deep diving on the foot and how it connects to the pelvic floor and impacts the pelvic floor, but also we can't just look at the foot when it comes to anything, right? So we're going to kind of zoom out from the foot. If you follow me for any period of time, I always say we've got to zoom out of the pelvis. So in a similar way, we're going to zoom into the foot. We're going to get real familiar with the biomechanics and what that's doing at the pelvic floor. And then we're going to zoom out again, and we're going to look at kind of the big picture of from the ground up, what's happening. So that's what we're covering today. My full kind of method or framework, whatever you want to call it, includes all this other stuff, right? And this is important to share because, again, I think so many people call me like I'm the foot girl, and like I am, like what a compliment. And I consider myself like the foot girl who understands how the foot connects to everything else, right? So in my method, or how I treat my patients, what actually is the most important is that we learn how to ask better questions, right? Our subjective portion of our evaluation, examination, assessment type stuff is hands down the most important thing. So much more important than any fancy manual assessment, manual technique, anything like that. We don't go deep into that today just for time's sake, because I do want to do a deep dive on the foot. But just know that's so, so important. If we are not taking the time to listen to our patients, we're missing everything. It doesn't matter how good you are at the foot. You're going to miss so much of what's likely happening. Also pelvis biomechanics. We love a good pelvis biomechanics. I got my handy dandy biomechanical pelvis there. Specifically, I love to nerd out on what my patients' iliums are doing. So are they, we tend to see a lot of patients that lack ilium internal rotation, or they're kind of stuck in like this anterior orientation. They kind of prefer to live in that like anterior tilt, which is not a bad, like anterior tilt. I'm not here to say that's a bad thing. I'm just like, we gotta be able to get out of it. Side note, some of these people can't get out of it because of what their feet are doing. So we're gonna talk about that. But pelvis biomechanics is a huge part of what we need to be able to assess as well. Obviously, that's one of the more obvious ones, pelvic floor, pelvis biomechanics, right? So that's a huge part of what I do with my clients as well. And then of course we move to the foot and the ankle biomechanics. Today we're foot. I'm not even really going to have time to get into ankle, but they obviously work, hand in hand together, hand in hand, foot and foot, whatever you want to say. But yeah, so again, like foot and ankle, they're literally connected. They also function biomechanically in a chain reaction up the entire lower extremity, up to the pelvis, to the pelvic floor, pressure management, force absorption, all that stuff. So you really do have to be able to understand everything I'm about to teach you zoomed into the foot, how that goes with, okay, what about the ankle, the tibia, the femur, the ilium? What about the ribs? Oh my. Moving down, so the rib cage and the thorax, right? So this one, all of you pelvic floor therapists, or people who have just even like learned about rib cage and breathing, you're probably like, yeah, like breathing, like it is important. Yeah, ribs. Yeah, we want to be able to breathe. We know that breathing is important for good pelvic floor function. If you have not learned that yet, that's okay. I'm not trying to call you out. I'm just saying like a lot of us have probably already learned how important proper breathing and diaphragmatic mobility is for the pelvic floor function. Where I take that even a step further is actually looking at the muscles that attach the rib cage. So we're looking at internal and external obliques. We're looking at serratus anterior. We're looking at all of these, all of these muscles that attach from the sides, the front, the abs, right? From the back, all the fascia and everything like that. How we can utilize those things to affect change on where the rib cage is in space. Is it, more anterior, more flared? Can we utilize some of those muscles to kind of, maybe we're looking at some obliques to kind of help bring it down. Maybe we're looking at serratus anterior to kind of get this reach that kind of helps pull rib cage back. But anyways, I digress about the ribs because that's a whole other workshop. Okay, we'll get there. But it's so important. So I didn't want to just skim past it because it is important if the ribs and the rib cage is a root cause or a main driver of your patient's pressure management symptoms. So then I also don't want to skip over the holistic kind of non-biomechanical considerations. It's so important this kind of goes with asking better questions. It's so important to understand the history of your patients and understand even like their childhood, like bowel movement habits and like random things like that. It's important to get a lay of the land of their emotional well-being now and in the past, right? Like how has their anxiety impacted or is it correlated with their symptoms and things like that? So didn't want to skip over that because that's very, very important as well. All this is so important because we're holistic practitioners, right? And then, of course, as a physical therapist, exercise and manual therapy prescription is one of, not the only, but it's one of the most important things I do. Another one I would say is like education, coaching, helping with lifestyle changes, stuff like that. But all of that kind of makes up what I would say is like my method or my framework, basically how I treat my patients and how I teach people to treat the pelvic floor without Kegels. So, like I said, today we're going to zoom into the foot. So that's why you're all here. We can move on. Before we get into the actual biomechanics, I always like to just kind of think through, like, let's make sure this is the right workshop for you. I think it is because I'm really excited about this. But this workshop is going to be great for people who are going through some of these things. So I'm just going to read them off because I'm wondering if it's going to make you kind of be like, oh yeah, that's me. Oh yeah, that sounds like me. And there's just power in knowing you're not alone, right? So as I'm kind of reading through some of these, if you want to be superstar participant, you can put in the chat like, oh, like number 2, that's me, or like 2 and 6 or whatever. So that way people just, like I said, it's always nice to know that we're not alone. So you're in the right place if you are able to keep your weightlifting client leak-free, maybe by cueing a Kegel or a pelvic floor contraction during their lifts. But as soon as they perform the lift, without that pelvic floor squeeze, they leak again. And you can't seem to figure out how to make their pelvic floor work automatically like it should be. Maybe you notice that your leaking runners tend to complain of other issues alongside their leaking. Maybe they have a history of ankle sprains, knee pain, hip pain, and you're sensing that these things are related to their leaking, but you don't know where to start with assessing their lower extremity and tying that into their leaking. Your patients with prolapse, they have to continually perform pelvic floor engagements or contractions or Kegels throughout their day to manage that heaviness and pressure symptom. Maybe you don't know how to get them to stop relying on Kegels to manage, symptoms throughout their day. Maybe this is a story that you've experienced. Postpartum client comes to you desperate for help with her leaking. After a couple sessions, focus on breath work, so important, right? Focus on breath work, pelvic floor engagement. They say they're only feeling slight improvement. By the 3rd visit, they email to cancel their next appointment, right? They're going to go try a different provider. That one's the worst. I have been there and I'm just like defeated. I'm like, oh my gosh, like it sucks because you want to help these people, right? And you're just like, oh, what did I miss, right? Runner comes to you because they leak every time they try to sprint or push their pace. So you cue them to lift their pelvic floor, or maybe it's to focus on their core engagement. While it works a little during their lower intensity runs, the leaking returns as soon as they increase their speed or go a longer distance. They're frustrated, you're frustrated, you feel like you've hit a wall. You're just unsure how to help them beyond like some of these basic modifications. And maybe you just feel like you don't have a big enough toolbox. So it's not that you're not already helping your clients in some way. I really am confident that you are. It's just those cases that you can't quite get them past that 80%. You're just missing all the tools that'll help get them to that 100%. So, if you are like, again, this is another spot where I kind of want to just bring us together. We're better together. If you're like most of the providers that I work with, so most of the people that I teach, I run a clinical mastermind, right? A lot of the people that are in my mastermind started off like this. A lot of people that take my course started off like this. So maybe you're cueing your patients to contract the pelvic floor during the hard part of the movement, but you don't know how to progress them past that, right? That's not a bad thing. It's not a bad thing to teach that engagement during movement, in the early stages of neuro re-ed, but if we can't move past that, all we've given them is a compensatory strategy. So that way they can stay dry during their heavy lifts or whatever, right? So if that's the thing that you're getting stuck on and you're like, ugh, like it works, but now my patient has to do this forevermore, then I would argue, and I've been there, trust me, I would argue that we've just given them a compensation, a compensatory strategy to allow them to keep lifting and working out, which is a good thing. But did we really fix the problem if they're having to do that? I vote no. Maybe you prescribe generic core hip strengthening exercises, clamshells, TA activation. You're expecting those to keep your patients leak free when they run. Newsflash, they're not gonna, okay? They're not gonna. You decrease the amount of weight your patients are deadlifting to an amount where they don't complain of the pressure. You do this instead of determining why they're feeling the pressure and fixing the why, right? Maybe you've heard that the foot, hello, this workshop, could be contributing to your clients leaking. So you prescribe them some generic exercises like a toe yoga, arch making, and you're like, okay, like I've heard that the foot does some stuff. Let's throw some stuff there and see what happens. So you're kind of throwing some random foot stuff at them. You keep prescribing breathing exercises in positions like child's pose, happy baby. You're trying to promote that pelvic floor relaxation, but you haven't really determined why the pelvic floor isn't relaxed in the first place, right? So your clients are never actually improving that tension. They're now just, again, stuck managing it with these breathing positions forever. I also just want to pause here and say it's never a bad thing to give our patients and clients strategies, ever. What I am arguing for is like, let's get to the root and see if we can make it to where they like don't need these strategies daily. Maybe it's something they can fall back on in a flare. Great. We love some independence, right? But I'm just trying to get you to think a little deeper and go a little past, oh, just do your child's pose every day for the rest of time. Like, I'm not trying to do that. And then last one, you prescribe supine exercises, bridges, dead bug for your patients with prolapse, right? Those are some common ones that we've been taught to give for prolapse. Again, I'm not vilifying those exercises, but I'm just saying what happens when they stand up. As soon as they stand up against gravity, they're reporting heaviness, pressure symptoms because they're on their feet all day and you just train them in supine, right? So these are very common. This is not just you. Hopefully you guys have been able to see in the chat people, again, I'm not looking at it, but hopefully you're able to see that you're not alone and that so many of us struggle with a lot of these things and we mean the best for our patients and we really want to desperately get them out of these symptoms. The thing that we're missing though is we've been taught to give compensatory strategies, not actually find the root cause. And not today, because I'm going to teach you the foot root cause today. So I was there too. That's why I know like literally every single thing on those past two slides that I just listed out for you guys was like part of my story, right? That's probably why so many of them are relatable because I didn't just make them up. That's stuff that I've personally run up against with my patients in the past. So that's literally why I want to educate you guys. That's why I want to have this workshop. That's why I don't stop posting on social media and sending emails about the freaking foot and like, you got to zoom out of the pelvis, right? Because it really matters. And it completely changed whenever I learned about the foot and how I could use it to positively impact my pelvic floor patients. Like it changed my life because it changed my patients' lives, right? And it opened my eyes to how I can just better help them. So it's my why, right? That's why I won't stop with my megaphone shouting it from the rooftops. But let me share a little bit about this patient. So this is an old patient of mine. She has given me permission to share. She's in my I treated her, let me think, probably like 3 or 4 years ago now. She was in my first couple years of being a clinic owner. And to this day, probably one of my favorite patients ever, ever, ever. You know, you just have those ones. And I was working with her at the same time alongside I started to learn the foot stuff. She came to me, a runner with leaking and prolapse. She had a grade 2 cystocele, pretty symptomatic, heaviness, pressure, bulge sensation. And then the leaking would happen with running. And she's a runner. She loves running. So the leaking would happen with running. And um, it would also happen. She described it as like whenever I'm reading stories to my girls at bedtime and I do the silly voices and I'm like, oh my gosh. And like she's, screaming on a screaming part or whatever it is. She's like, I would pee my pants, like screaming, whatever. So that's a little bit about her. Specifically with the running, you can see some of these pictures of her, and we're going to get in a little bit more to this, but specifically on her right foot, look at this picture over here to the left. So you can kind of see how her foot strike is very much in the lateral aspect of her foot. She, she's going to go with the heel strike there, and she's really going to be on like that blade, that outside blade of her foot as she kind of brings that foot down and lands, okay? And then you can see once she lands, look how much she kind of collapses into that pronation. And I'm like, I need my glasses. I needed to make these bigger. So you can imagine as she's landing, if she lands in the lateral aspect of her foot, and it collapses in that much and that quickly, you can imagine that's going to have more force associated with it rather than if we didn't start from way out here and then collapse into it, right? So just stay with me. I'm going to explain that a little bit more. And then this is just the one on the right, just a picture from the back where you can a little bit see how she's just on, like you can even see um, the heel of that right foot. There's space on the medial aspect of the heel. There's space. She's not even she's in mid stance right there, and she hasn't even contacted the ground with the medial aspect of her heel. So I was working with this patient alongside the same time I was learning all my foot stuff. And she was so excited because I was like, Melissa, oh my gosh, I just learned that if you're running and you're, landing super supinated and maybe you're collapsing into pronation like in an uncontrolled manner, like it's going to make your leaking worse. And like both of us were just like mind blown. And so I started to implement a lot of this stuff I'm going to show you today with her. And she went home, did her stuff, came back like a week or two later, and she literally was like, Becky, I did those weird foot things you gave me, and I went on a run, and my leaking was 90% gone, like bare, like just little dribbles. So, I just want to share that with y'all because this is one of the patients that really fueled my passion because like I got a taste of like, ooh, like maybe there's something, to this foot stuff that I need to dig deeper on because that was the first thing to really move the needle for her. I had done everything else. Everything on those last slides. I'm like, we had done the bridges. We had even done the single leg strengthening. We had done the glute strengthening, all the things that they teach you. And she just was still leaking. So I just want to share that story. She's a happy story. Also, I wanted to share some of these other lovely ladies who offered to let me share kind of their story with my method and kind of some with the foot stuff, some with the rib cage stuff, some with the whole picture stuff. And I just wanted to quickly share them with you because again, I am a big believer that we're better together and there's power in numbers. And when we know we're not alone, it's helpful. So I'm just going to play these, or this one, hopefully you can hear this one.
I truly can say, as someone who has been able to become extremely confident in her practice, a year into her practice as a orthopelvic PT that is now also a birth doula, that the understanding and synthesization of the biomechanics of the body through Becky's course has made me a better clinician from the get-go. So I'm very thankful for Becky and her brain and her team.
Sweet Emily. Emily was a student at Genesis. She moved to Austin. She moved away from us. And then there's Allie. Allie is actually one of my PTs at Genesis. She is at our Addison clinic. And she sent me this quote um, to share with you guys. She said, I've been struggling with a patient with stress incontinence that resolved during her daily activity, but not with running. I reopened your course. I rewatched it with this patient in mind. I reviewed my notes, my videos, and I caught things I had missed. I reassessed her movement. I gave her new cues. I mobed her foot and ankle and revamped her home program. And not 7 hours later, she messaged me saying she's already noticing a difference. Her glutes are on fire because that's what happens when we find our midfoot, y'all. Thanks for this incredible course that grows with us as clinicians. That is something that in my full course, you guys get an exercise library if any of you guys have taken my full course. And I'm telling you, people message me all the time. Oh my gosh, this exercise library of like there's over 70 videos in there broken down by hip and pelvis, foot and ankle, rib cage, thorax, like things like that. And that's consistently what people tell me that they love to refer back to in that course. And then I have to share Colette's story. I know that there are some of you here. I don't know if you're here live, but I know that there are a handful of you guys here who know Colette because you'll message me or she's messaged me or something. Let me tell you guys her story because it's going to blow your mind. So she is a pre and postnatal fitness coach. She's over in the UK. And she's actually been kind of in my, what is it called? Stratosphere ecosystem. I don't know. I've known her virtually for a few years now. And she actually took the first cohort of my course. And since then has joined my clinical mastermind. So she's been in that thing since day one. So 3 years now that has been running. We've kept in touch over Instagram and y'all, like I said, she's a pre and postnatal fitness coach. She, since learning all this and since seeing how horrific, y'all think America's bad with how we treat the pelvic floor. It is so much worse over there from what I hear from her because it's all pelvic floor squeezes and whatever. There's my accent. So for the only time I'm going to do it. And she has since decided to go to physio school and become a physiotherapist, which she is in. I kind of have walked with her through this application process. It took her a year to get her stuff together. She had to finish some prereqs. This can be a second career for her, right? Like she has a thriving business as a coach. But she was just like, Becky, like the physios over here, I'm battling them because I am learning all this stuff. I'm working with my clients with prolapse and leaking, and I'm, giving them this foot stuff, and I'm having to tell them like to stop doing the Kegels that their physiotherapist is telling them to do. And it's like this fine line. So she was like, I'm just going to go back to school. So I've gotten to watch her like evolve over the years. And that's the definition of change the game, right? Like she's about to blow it up over there in the UK, and I cannot wait to watch her do it. She's one of my favorite people I've ever met virtually. Hopefully I get to meet her in person one day. But I love this quote from her. I am not going to sit by while half the population is ignored. And if that doesn't describe Colette, it just does. Okay, that is her. So make sure you give these girlies a follow because these are for sure some game changers. Oh no. Okay, y'all close your eyes. It skipped ahead. Okay. So, oh, there's some fun foot stuff. Okay. So, what makes my approach different? So, when we're talking about to the pelvic floor, right? My approach to treating the pelvic floor, I have learned how to integrate both a top down and a ground up approach. So, the ground up approach is kind of what we're looking at today. We're about to dive in deep to that. You really need both, right, to be able to treat the pelvis because the pelvis is the central hub of our body. Its main job is to transfer loads and forces as we walk or get up from the chair or hold our kid on the side of our body or whatever it is. So you do kind of have to understand both. Obviously, today we're going to do the ground up because we're going to look at the foot. But that's what makes my entire approach different is because we zoom out of the pelvis and we look kind of from both directions. And that's what helps us find really the root cause. So that way we can really get our patients lasting change instead of these compensatory strategies that we've been taught to give them. So a lot of people who claim to not be using Kegels, they're actually still teaching these Kegels, right? This is kind of what we were talking about. Even if it's not the do your 10 Kegels at stoplights, they're teaching them, long term with the lift and stuff like that, or to manage their prolapse symptoms. Or they're hyper focused on pelvic floor relaxation exercises in the name of like not using Kegels, because there's like this pendulum, right? There's like God forbid I get over here on social media and say Kegels are not necessary. The police come after me almost. It's just wild out here. It's the wild, wild west. But then there's also the pendulum that swings over here. And then there's the people that say Kegels are absolutely necessary. There's so much research to support it, blah, 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 blah. And it's like this thing that swings back and forth, right? And what I want to say is, I want to say there's like no absolutes. Like, let's figure out why the pelvic floor is not working instead of just saying, oh, it needs to be stronger, give Kegels, or oh, it's tight, just give relaxation for the rest of time, right? Let's do better is kind of what I'm saying. Um, the problem is not Kegels. It's the fact that they're not addressing why, right? That's kind of what I just said. They're not addressing why the pelvic floor muscles are dysfunctional in the first place. They're not determining the true root cause or causes. So honestly, most of us probably know that Kegels, like saying do your Kegels at the stoplights, are not the answer. If you've been attracted to my content and stuff like that, my guess is that you're probably like, yeah, like burn the Kegels, right? But we just don't know what is the answer, and that's what I'm here to give you a framework for that will show you today. Foot stuff. Um, so let's get into the framework. This is that picture again from the beginning. So the whole framework, right, is what will provide you with the clearly defined, easy to follow process for assessing and treating. So that way you can get to the root cause and get your clients lasting relief. Like I said, today we're going into the foot. So let's do it. Okay, let me get a sip of water. All right. The meat and potatoes, what everyone's waiting for. My favorite part. Why do we care about the foot? So, as it pertains to the pelvic floor, I mean, hopefully we all care about our foot. Like we want to have a foot so we can like stand and walk. But as it pertains to pelvic floor function, why do we care? Main reason being that the way our foot hits the ground, so go back and picture my patient Melissa hitting the ground on that lateral aspect. The way the foot hits the ground and thus absorbs the load or the force is going to set a chain reaction and impact everything above it. So if it hits on the lateral aspect, that's going to do one thing for that chain reaction. If they hit and they slap into pronation, or they just hit super pronated already, which is a little more rare, that's going to do something up the chain. And the chain being right all the way up the tibia to the femur to the ilium, which is where our pelvic floor is attaching and being affected from the bony aspect of things. So it's so crucial that to understand that you can improve your patient's hip mobility, you can improve their pelvic floor tension all day long, but if you do not address like their foot, assuming that the foot has a problem, which a lot of people do, the person is going to fall right back into the same patterns as soon as they stand up and start moving, right? We've seen this in our patients. We do a lot of internal work. We dry needle the glute med and the piriformis and the TFL and the iliacus and all these lovely things that make them feel better. We do some hip mobs. We do whatever it is that we do, right? Where they're laying on the table and we're doing all this manual stuff. Again, helpful things. I'm not saying I use manual therapy all the time. So don't hear me saying like you don't need to do that stuff. But the problem is if the root is coming from the foot and how the midfoot is moving or not moving, they're just going to stand up and they're going to walk away from your table and go back to doing their offending activities, and their symptoms are just going to be a little better maybe, or not better at all, or maybe they're all the way better but they just won't stay better, right? Because the problem is in the kinetic chain starting at the foot. So just that's kind of like the big point of like why we care, because as pelvic floor therapists, which a lot of us are, doing all this pelvic focused stuff is good unless that's all we're doing. Okay, so just keep that in mind as we kind of work through this. Unlocking the foot either literally because it's a stiff foot or unlocking it like in your brain is going to unlock the whole chain. So, and thus the pelvic floor. So when we talk about the kinetic chain, big picture, it big picture coming from the ground up is this first bullet point. So we have this midfoot pronation, which I'm going to talk more about in a minute. So don't be like, what's midfoot pronation? We have this midfoot pronation when we go into this mid stance, right? We take a step, we walk, we kind of absorb that load, absorb that weight, absorb that force. We go into midfoot pronation, or we should. From there, that the kinetic chain kicks off. The ankle moves into dorsiflexion. Our tibia should go into internal rotation ever so slightly. Yes, the knee rotates. Our femur above it's going to go slightly into internal rotation. And then the ilium, the actual pelvic bone, is going to follow the femur. So we have the femur kind of turns in a little bit, and then the ilium turns in ever so slightly with it. Okay. That is critical to your patient's pelvic floors working automatically, anticipatory, in an anticipatory manner, and working without them having to think about it, which like in something like running, it has to be anticipatory and responsive, right? So we're gonna revisit that big picture thing a few more times. So don't be like, wait, what? Like if this is a new concept to you, we're gonna hit it like probably 3 or 4 more times today. So don't panic. But that's critical and that's crucial for your patient's pelvic floor ability to work, to support the organs, to clamp off the urethra, to keep them leak and pressure free. Because when that happens with our ilium, when we get that internal rotation of the femur and that internal rotation of the ilium, you can imagine the pelvic floor that lives here at the outlet at the bottom of the ilium. If we get that internal rotation, that outlet widens, okay, which is going to like eccentrically lengthen and ascend the pelvic floor, posterior pelvic floor. So that's why it's important. Again, we're going to revisit this in a little bit, but that's kind of the biomechanical connection of if we don't have that midfoot pronation at the beginning of that sentence, it's affecting every other touch point up the rest of the chain, all the way up to now the ilium might not have as much IR, which means now the pelvic floor can't lengthen eccentrically and reascend to support all those organs above it. And now our patients might leak or have pressure or have heaviness type symptoms. So that's kind of like the biomechanical picture of the kinetic chain. And please understand, like I know I'm drilling this part home, but it's important. Today we are going into the foot, but you don't get so hyper focused on the foot after today that you forget the rest of the picture. But main takeaway today, I want you to understand, if the midfoot isn't moving well under loads, which could mean weightlifting, could mean on a run, could mean walking, could mean carrying their baby around the house, could mean climbing a mountain in Colorado, right? If the midfoot isn't moving well under these loads, your patient's pelvic floor is not being given the adequate opportunity to work automatically and keep them symptom free. Okay, because that's our primary goal, is to it's less about retraining the pelvic floor in this sense, to be automatic, and it's more about setting it up for success via getting the bony pelvis moving in the right way to allow for that length tension change and to allow for that reascension automatically of the pelvic floor. Okay, hang with me. So you heard me say, right? If we don't have that midfoot pronation, then that whole kinetic chain is likely gonna have something messed up or some compensations or miss out on some range of motion, and the pelvic floor is not gonna work and all that stuff, right? So on the other hand, haven't we been taught pronation is bad? Like I don't know, put it in the chat, like who, and even if you're not like, oh, I've been taught it's bad, maybe you've been taught we need to like put an orthotic in our patient's shoes, or we need to put them in a supportive shoe, right? A supportive shoe that's gonna have arch support even, and like all of these things in an effort to kind of not let our patient fall into this pronation. So just put that in the chat if you're like, yes, either I've been taught that or that is how I think or whatever. But we hear it, right? We hear it causes us plantar fasciitis. We hear it causes our knees to cave in and our ACLs to tear in half. I got a little carried away on this slide. We hear that it causes global warming. Who's heard that one, right? I want you guys to start reframing this negativity around pronation. Pronation is necessary. Pronation is not the bad guy. What the bad guy is a lack of control of pronation. Okay, and we're going to get into that. We're going to look at some videos. I'm going to give you some stuff. But I really want you, especially if you're someone who tends to go towards putting your patients in supportive shoes or wanting to give your patients arch support, just have an open mind here. And I want you guys to be thinking critically of like, okay, so if pronation's not the bad guy, why do I feel the need to try and control that pronation? Oh, okay. So is there a way that we can control this pronation more automatically, more naturally with the patient's own body? Yes. Yes, there is. Because pronation is necessary for optimal movement and function, including function of the pelvic floor, right? I just kind of gave you that kinetic chain thing about how that creates this reascension at the pelvic floor to support the organs and keep us leak free. So if we lack pronation range of motion, whether it's from a stiff foot that doesn't pronate well, I'm going to show you pictures in a second, um, or whether it's because we put them in a super supportive shoe or they're wearing an orthotic. So any of those can cause a lack of pronation range of motion. Um, or if we lack this eccentric control of this pronation, meaning so eccentric, right, is a muscle contracting while it lengthens. Okay, so if we go into this pronation, the muscles are lengthening both at the bottom of the foot and the tibialis posterior is one of the muscles that controls the midfoot eccentrically. So that's just one that comes to my mind. That's a really important one, actually. So those are going to lengthen as we go into pronation, but we need those muscles to lengthen in an eccentric and controlled manner rather than just be like, oh, I can't, like I give up, like we're just going to collapse into pronation, right? So super, super important that we have to have the range of motion and our patients have to have this eccentric control. If they don't, if they have that stiff foot or too much arch support, or they're lacking that eccentric control and now we're just falling into pronation, then that's when we see things like leaking, prolapse, pelvic pain, knee pain, hip pain, IT band syndrome, SI joint, foot pain, ankle sprains, right? All these things, all freaking because the midfoot, like it all starts there, right? That's where it starts whenever we put our foot on the ground. And so it's like so important. If that's not doing what it needs to do, then we're going to see all these compensations up the chain. Okay. What the heck? Why is it doing that? Okay. Here is the next one. Okay. So, kind of going into this isn't pronation bad thing. So we have I want to just kind of retouch on what is pronation, just in case people need like a update on what it is biomechanically. So it's actually a coupled motion, which means it's like a combination of different like planes of motion. So pronation is coupled motion at the subtalar joint, and it includes a combo of eversion, abduction, and dorsiflexion right at that subtalar joint. I think of pronation, if you think of all of those three things that I just kind of mentioned all tapping together, think of it as like the entirety of the foot just kind of like internally rotating, right? So I kind of say pronation is foot internal rotation. That's kind of the way I imagine it and the way I talk about it now and the way I teach it now. We also have this inferior motion of the navicular bone. That one is a key player in the ability to pronate, in stability of the medial longitudinal arch. Look at me remembering my anatomy. And I'm going to go into that in a second. And this measure down here, it's a good way to measure your patient's ability or range of motion to go into pronation. And it's a good kind of marker for gaining range of motion. Some of you guys who filled out that form I sent out with what do you really want to learn? There was a good amount of you guys that were like, what are ways that I can measure kind of this foot pronation motion up like objectively, rather than just going off of patient symptom report, which is good, or like my eyeballs or whatever. Well, this is how you can literally measure the navicular drop, and there's tons and tons of studies that show that or that have validated like navicular drop measurement for ability of the foot to pronate. So let me show you this video up top right quick. So this is going into pronation. So you can see the arch flatten. Supination is kind of a recoiling. The navicular bone, which is this guy right here, drops down. And see, and you can kind of appreciate that entire internal rotation moment. I'm gonna play it again. Picture the entire foot rotating towards the camera a little bit, like as it goes down. And now it's gonna kind of externally rotate as it goes back into supination. So there's some internal rotation and some external rotation. Okay, so that is obviously a model that moves perfectly. I would even say probably more than normal, but it's helpful for illustration purposes of what pronation looks like. So let's talk about this navicular drop test. Literally, I learned this in PT school, and in my way back whenever I was in there years ago, I was like, I'm literally never going to use this. Like, when would I ever take out a ruler and measure someone's foot bone? Okay. Um, well, it's been halfway true because honestly, to this day, I don't measure it. I just kind of eyeball it, but you can literally take out a ruler. And what you do is you get them, obviously take off their shoe, and you get them standing, and you can give them something to kind of balance on. You kind of want them to be mainly their weight kind of mainly on the foot that you're looking at versus on both feet, because you're gonna kind of cue their where their weight is shifted to kind of get the subtalar joint in more neutral. You kind of want to, instead of it already being falling into pronation, you want to make sure that subtalar joint's a little bit more neutral. So you'll kind of look at that from the front and from the medial aspect, and you can kind of cue them, okay, shift your weight a little bit this way, or do this, to kind of get that starting from a neutral subtalar position. And then the cue, well, before you give the cue, you're going to take the ruler and you're going to measure from the ground to the navicular tuberosity, which is that bony prominence, like basically just inferior and superior, no, inferior and forward, anterior, to the medial malleolus. So that big old bone, the one that's slightly smaller than the medial malleolus, that's your navicular tuberosity. So you're going to measure from there to the ground and see how many centimeters it is. And then all the cue you're going to give them, because remember, you kind of got them in this subtalar neutral. They might be kind of having to hold that, or they might feel kind of like they're not all the way balanced. And you're going to say, okay, relax. And then they'll just like relax into that. And you're going to measure where that navicular tuberosity goes. And I pulled these numbers from an article that was listed on Physiopedia. The link's down there to the Physiopedia, not to the article. You can find it on the web page, whatever. Point is, I didn't make these numbers up. Okay, people? So I pulled these from an article, and what the navicular drop test tells us is if that navicular tuberosity descends less than 5 millimeters from subtalar neutral, whenever you kind of have them relax into it, that's kind of like a stiff or supinated foot. What that kind of tells us they don't have as much pronation ability. Okay. And then neutral foot, so this is kind of where we would hope to get most of our patients to, is a 5 to 9 millimeter drop. And then a pronated foot, or I would call this an overpronated or an uncontrolled pronated foot, is going to be more than a 9 millimeter drop. Again, am I whipping out the ruler in my clinic? No, to be honest. I do eyeball this test though. It's a really quick and easy test, but maybe you start with the ruler with some patients if this is new to you, and then you can, once you've done it a few times, you'll kind of have the eyeball for it. But even just in this guy's foot, you can see from that like neutral A to B, he kind of got, I would argue that that's probably within neutral limits. You can kind of see there's still some daylight underneath this arch here. So that foot looks pretty okay to me. But let's talk about what this means at the pelvic floor. Okay, so we're gonna, like I mentioned in the kinetic chain bullet point. So we need the foot to be able to move into pronation. We do also need to be moved out of pronation into supination. Okay, so I'm not saying we're gonna live in pronation. It's just, it's a lot more common though to see people who um, tend to lack pronation ability. So that's kind of why I'm honing in on that. But pronation is tied with pelvic floor ascent. Okay, so moving back up. That's because of that kinetic chain, right? That's because if pronation is this internal rotation of the entire chain, we have foot IR, ankle dorsiflexion, tibial IR, femoral IR, ilium IR, IR up the chain. That ilium IR widens the pelvic outlet and allows the pelvic floor to spring back up. Okay, because it's kind of hanging out here in this like semi-descended state, and then we get that internal rotation and it springs back up and supports all those organs. Okay, so if pronation kind of pairs itself with pelvic floor reascent, then supination, for the opposite reason, is going to be paired with pelvic floor descent. Okay, because if supination is going to be everything the opposite, it's going to be more externally rotated throughout the kinetic chain. When we have an externally rotated pelvis, okay, imagine my hand is the pelvic floor again, kind of neutral pelvis right here. If I externally rotate the iliums, the pelvic outlet starts to become approximated or smaller, and now the pelvic floor is descended and kind of sagging down there more than just at neutral. And so if you're thinking through that, think of our prolapse patients, right? We don't need them to have more descent, the pelvic floor. We need that pelvic floor to spring up and lift that bladder, lift that uterus, lift the rectum, lift everything, right? Like let's lift it. And so if we're not addressing these prolapse patients' feet and we're not making sure that they can get into that midfoot and get into that pronation to allow that whole chain internal rotation, we're not setting their pelvic floor up for the success to have that automatic kind of respringing. Okay. So this is why we get stuck cueing them this active Kegel during a lift or while they pick up their kid or whatever. It has nothing to do with the fact that it's wrong to be able to voluntarily engage our pelvic floor. That's a function that we have. That's fine. What's happening is we haven't changed why everything's so descended in the first place because we haven't addressed it from the ground up. Okay. Um, think back to my runner, right? She lands super supinated. So she's landing right on this lateral blade of her foot. She is setting up that entire freaking kinetic chain. I will never forget the moment I figured this out. And I was just like, I get it. Oh my gosh. She's setting that entire kinetic chain up to be externally rotated, which is descending her pelvic floor. She has a grade 2 prolapse, right? We know it. I saw it. She knows she has it. So it's just every time she lands in her running, her right side was worse. That's why I had the pictures there. But every time she landed, her poor little pelvic floor was getting even more descended. And so, like, no wonder she was leaking. Then I gave her those foot exercises. We got her into this like midfoot pronation, 90% better leaking after one day. Like, I think I gave her like two. I think I gave her like two of the things I'm going to show y'all today. But yeah, just wild, y'all. Okay. So let's review again. How does pronation affect the pelvic floor? I know that we need to hear this 5 million times to fully grasp it because it is like a new concept for a lot of us. So we're going to come back to this big picture kinetic chain thing. Okay. So midfoot pronation, which is, you can also think of that entire kind of foot internal rotation moment happening. Specifically, think of like in a mid stance. Okay. Think of like, okay, I'm coming over my leg, my weight's kind of over my midfoot. I'm in that like mid stance moment. We tend to kind of like deadlift from a mid stance type of vibe. So that midfoot pronation, that foot internal rotation, specifically during this mid stance, needs to be happening to allow things like ankle dorsiflexion, tibial internal rotation, femoral internal rotation, ilium internal rotation. So full chain internal rotation is necessary to give the pelvic floor its ability to reascend, right? Think of the trampoline, it gets descended and then it goes boing because of the link tension relationship. It needs to be able to reascend, support the organs that are sitting on top of it rather than just being super descended because now we're externally rotated. Okay. And keep your patients leak and pressure free, right? The leaks are happening because the length tension relationship of the pelvic floor is inadequate. Because if we're super externally rotated and stuck in kind of this supination, think back to like that length tension lecture in your school, right? It's like if we are too lengthened or too shortened, the muscle can't do its job. Same thing here at the pelvic floor. If it's too kind of descended, saggy, we don't have adequate link tension, it's not going to be able to clamp off the urethra to keep the pee in when we have that increase of force, increase of pressure. Because bony position of the pelvis, because of the foot. Okay. Breathe. We're doing great. Y'all are doing great. So we need pronation ability, which is the range of motion into pronation. And we need to control that range of motion. This is true for every single joint in our body, right? Every single joint. We need to have its proper range of motion. And also, let's control the range of motion so it doesn't go too far. And we don't see injury, on going too far into the range, right? Same exact thing at the foot. Why would it be any different, right? So, lack of pronation range of motion, the rest of the kinetic chain is going to miss out on that internal rotation as well. The pelvis is, or you can think of the iliums, are going to remain externally rotated, and the pelvic floor is going to remain kind of short and descended state. The organs won't have as much support. The urethra can't be clamped off as effectively because of the link tension problem. And the pelvis can't even be stabilized as well, right? Think of our pelvic girdle pain, mamas, okay? And gosh, pregnancy, right? Your iliums are so externally rotated and probably anterior. And if we're not treating their feet to be able to ensure that they're not getting that foot turning out and that like waddling gait and never getting into pronation, y'all, like this is why they're having pelvic girdle pain, okay? So that's where this heaviness, prolapse, pressure, leaks, hip pain, low back pain, pelvic pain comes into play. Lack of pronation control, maybe they have the range of motion, but they don't have the control. Now we're going to have more internal rotation torque and demand because now they're just falling into it, placed on the remainder of the chain. Okay, and that's going to have its host of problems because we're going to see poor eccentric control of the entire chain, right? We don't only need eccentric control of pronation, we also need it up at the femur, right? We need the glute med and the obturator internus and the piriformis and all these things to not let that femur go past its normal internal rotation range of motion, okay? Hopefully it's starting to click. So what's the solution here? We need to ensure that our patients have adequate range of motion in the first place. I just kind of hit that home. If they don't, I'm going to show you some manual therapy and some exercise interventions here in a second to help restore the midfoot mobility. If they do have the range of motion, but they're still kind of falling into too much of that uncontrolled pronation, then we need to strengthen the eccentric midfoot stabilizers like the posterior tibialis, however you want to say it. You also keep in mind, if you have this person falling into this pronation, keep in mind you got to rule out hip eccentric weakness. That's kind of some of that stuff I just talked about. I talked about like the obturator internus, the piriformis, the glute med. We got to make sure that those guys aren't failing, making the foot fall in. Also, we don't have time to go into all that today, but be thinking about that as well. If they have the good range of motion, but they're still underutilizing the range of motion, maybe they have it in the passive testing, right? But you're seeing like in active assessments and stuff, they're not utilizing that. They're still kind of staying supinated. Then you need to look up the chain again for something preventing the midfoot from going into IR. It could be the tibia, could be that you lack tibia IR, right? And so we're getting this kind of top-down block of being able to go into this internal rotation of the foot. Could be that femur, again, like I just mentioned, could be the ankle. Gosh, if they lack dorsiflexion, they're not going to get midfoot pronation, y'all. They're not. Where's their weight in space, right? If we're too far forward or too far back or whatever, or maybe we're more over on one side, that's all going to impact our brain's ability to get into and utilize our pronation. Rib cage, gosh, I got to do another workshop on that. That it matters. It matters. Okay, let me show you some of these things. I'm just going to show them to y'all. This is a midfoot mobe. So I like to just kind of pull their knee out into a little external rotation, and I have my thenar eminence on their navicular bone, and I take that navicular, see if I do it again. So I'm gonna take it to in range right there, and then I'm gonna mobe it at in range. You can also manip it here. Sometimes I'll do a navicular manipulation. This is going to be to improve pronation range of motion. Right here, I'm rotating her out even more for an even like deeper kind of internal rotation to get that manip. I'm retesting and I'm like, ooh la la, look at that motion. Yes. So that's that. You're going to get this recording, you guys, so y'all can go back and watch these. So here's some midfoot mobes. You can watch kind of my midfoot down there as I go into that mid stance. This is kind of more of like you can use this as a test, and then this is also like a neuro re-ed for your patients. Just having them sink into that while keeping their foot tripod in contact with the ground. Just going into that mid stance and just allowing that midfoot to go into that internal rotation. Okay, and then this last one, getting into a little bit of that tibia IR and dorsiflexion. So I have that band right there on the talus bone to kind of give it that kind of posterior inferior push as I'm internally rotating the tibia. I'm gonna show you that one more time. So as I go into dorsiflexion, I'm internally rotating my tibia because that should be happening together with dorsiflexion and pronation. This is a magic bullet exercise, y'all. You just give it to everyone. So good. Okay, so that's the solution for poor range of motion. There's some of them, some of my favorites. And then strength and control. Let's say they have the range of motion, you're doing strength. Now you need to make sure they have strength and control. These first two are for posterior tib. Okay, so this one, I want you focusing on the eccentric of this one. So I'm going really slow on the way down. So I bring that foot up into inversion, and then I'm not very good at it, as you can see. I'm trying to go slow on the way down. So that's a real easy, simple one, but the key is going slow on the way down because that's what's retraining that eccentric control that we talked about that's so important. This one's also for posterior tib. You put a little ball, a little tennis ball or something between their ankles. You have them actually rotate a little bit and do heel raises. And this works the posterior tib because when we're externally rotated a little bit and we go into a heel raise, the posterior tib has to work harder to control the foot not rolling too far in to pronation. So that one's pretty simple. Okay, these other two are a little more advanced and a little more, this is kind of taking that entire kinetic chain into account idea because I'm working on stabilizing myself on the single leg. I'm having to utilize the midfoot strength and control to be able to rotate into this band. You can imagine my left hip and glute are on fire because I'm keeping my knee, I'm trying to keep my knee facing forward and not rotate in. So this is relative pelvis on femur external rotation and working that midfoot control as well. And then in a similar vein, we have these single leg step ups and balancing. And I like to have them hold it a little bit. This band, what the band is doing is it's trying to pull me into, it's trying to rotate me into IR around my femur, my fem head. And so my brain is having to resist that and kind of control, not kind of falling into too much of that IR. So this is kind of working on that strength and motor control. Okay, another thing, just real quick, I want to touch on is you cannot forget their shoes, okay? Because like I've said, so many of us have been conditioned to get our patients in supportive shoes or orthotics or things like that. I cannot stress this enough. Our patients do not need, like our normal patients that don't have like, I mean, like EDS or like an injury or, things. I'm talking about like our normal people who don't have true like foot pathology. do not need orthotics. They do not need supportive shoes, you guys. They need a shoe that is wide enough for that midfoot to be able to expand under load, so a wide toe box, and preferably a zero to low drop. So any people familiar with like running shoes, they'll talk about drop a lot. I prefer 4 millimeters or below. Why? Because if we have a higher drop, that's putting us into relative plantar flexion, so AKA less dorsiflexion. And what does dorsiflexion go with? Midfoot pronation. Okay, that's why wearing high heels, women pee their pants more because we can't get midfoot pronation. Like that's literally why. And it pushes our center of mass forward. So shoes, shoes, shoes. My favorite type to recommend to my patients, and personally I wear them too, is ultra running. And I hopefully you guys saw that all of you guys that are here live and are staying till the end, about 5:30 or so, you're all entered to win a free pair. Ultra is partnering with me. They're giving away three. I only asked for one. I was like, can I gift one pair of shoes to my live attendees? And they were like, I'll give you three, Dr. Becky. And I was like, incredible. So you guys, y'all are going to get to try these Ultra shoes if you've never had them before. This middle picture, Ultra sent my entire Genesis team a pair of Ultras, which was super cute. You can see how adorable we are there. But shoes, shoes, shoes are so important. I wish I had more time to go into shoes. DM me if you want to nerd out about shoes, but hopefully you guys like them when you get to try the Ultras. So bring it all back. This is where I said we're going to kind of bring it all back to the big picture. The foot is my favorite thing to treat ever, ever, ever. And I would not help people as much as I do if I really didn't zoom back out of the foot, right? It's the beginning of the chain. We need that pronation, yes. And we need this dorsiflexion. We need tibial IR. We need all this IR up the chain to give our pelvic floor that ability. And that's just from the ground up, y'all. You have to be looking at it from the top down too. I just don't want you to think that I'm just like, we can cure world hunger with the foot, right? Like maybe we can, maybe we can. But you cannot forget the rib cage, and how that impacts the pelvic floor as well. Because rib cage, internal and external rotation, expansion, compression, all of that is so vital to the pelvic floor. So you just can't stop at the foot. So yes, oftentimes we're going to get results for our patients simply by improving this midfoot range of motion and teaching them to access it, right? Because they might have the range of motion, but if they're not getting into that midfoot and accessing it, then the pelvic floor is still not going to be getting what it needs. So we can do all this stuff and it can work magic, but also there's all this other stuff, right? Like everything I've been saying, like the entire kinetic chain internal rotation, the rib cage and how it's expansion and compression. IR and ER is going to change the pelvis and the pelvic floor. The initial eval, this is our asking better questions. This is like, I love to teach in my course, like why most of what we've been taught as pelvic floor therapists of the eval is trash. Like, I hate to say it, but it's worthless. And I'm looking at you, perf or perfect assessment, whichever one you want to call it. It's worthless, okay? We need to ask better questions to get better answers, to generate better interventions, to get better results. We need these specific biomechanical assessments and tests that tell you what's happening during their symptomatic activity at the pelvic floor. You need to know where to start once you assess this full biomechanical picture from the foot up to their head. You need to know how to integrate their patient's full picture with what's happening at the pelvic floor, like internally, right? I'm an internally treating and assessing PT. It's important. You need to know what exercises and manual techniques will actually help the person in front of you. And you need to know how to paint the picture of success for your patients so they're bought in. Some of you guys on your forum were like, how do I tell my patients about this foot thing and get them to buy in? And I wish that we could have gone more into that. We just didn't have time today, but like, that's important. Y'all are asking good questions. And you need to know how to not only help them achieve their goals and become symptom free without relying on, these pelvic floor squeezes and Kegels, but also like, let's be better. Like, let's take them far beyond their goals and like change their life better than they've ever imagined, right? Hopefully you're like, yeah, like let's change the world. Cause like, that's how I feel. And like, let's freaking change the world. Okay. Like, that's why I'm out here doing this. Okay. So I've got you. I mentioned, we talked a lot about like my whole method. I know this sounds like a lot, and it is. In some ways, it is a lot. It's the human body. It's never not going to be a lot. It's never not going to be complex. But this is why I outline my entire assessment and intervention framework for you in my course. So that way you can take what we learned today with the foot, and then you can learn all this other stuff and put it all freaking together in one big picture and go help your patients. My course covers every single bit of what we didn't have time for today. We literally talked about the navicular and the subtalar joint, and I tied it in with the kinetic chain. Okay, there's like an infinite amount more, okay, that is packed into my course that I would love for you guys to continue on with me and to do this next cohort. I'm going to tell you about it in a second. Um, Not only in the course do I go more in depth with the foot, you're going to get specific foot assessments, both functional movement assessments, manual assessments. You're going to get corrective exercises for the foot and the entire kinetic chain. There's literally an entire module dedicated to the foot and ankle. Like this is one piece. This is one piece slash this is a summary, basically, what you learned today of the module. You're going to go so much deeper in this module. We're also going to go over pelvic biomechanics, rib cage biomechanics. Then we're going to put it all together in a big digestible picture that's easy for you to understand. That's the key. It's easy, y'all. I make this so easy to digest and understand that you can go the next day and implement. That's people tell me that all the time. They're like, because the modules roll out once a week, and they're like, I love this course because I can do this module and then I can go tomorrow and I can work on all the stuff in the clinic. Then the next week I do this module and it adds to my knowledge and I can go implement it. And it just like keeps building. So that's what I hear. So if you're finding yourself interested in this course, which I hope you are, it's my How to Treat the Pelvic Floor Without Kegels course. So in it, you're going to learn this proven method that you can follow that's going to let you zoom out. I always say we got to zoom out. It's going to help you find the root cause of your client's leaking, their pressure, their prolapse, their pelvic pain, because it might be the foot, it might be the ankle, it might be the tibia, it might be the femur, it might be the rib cage, it might be their chronic history of constipation. Like it could be all the things. But this course is the answer that you've been looking for if a lot of this stuff has been resonating with you. A lot of stuff at the beginning, if that's kind of what you've been bumping up against and running into, this course is going to help you. It's going to help you stop teaching your patients to rely on these Kegels during the hard part of the lift, right? It's going to help you stop making your patients so aware of their pelvic floor tension and hyper focus on having to relax it all the time because you're actually going to fix the tension. Okay, it's going to help you. It's going to help your patients run faster and farther without leaking or hip pain, whatever. And it's going to get your clients results that last, y'all. It's rather than giving them these temporary management solutions, you're actually going to be able to find what the heck is causing the weakness or the tension, and why, and what can you do about it. So again, here's my full method. That's my entire course. We're going to talk about these. This is each module. So we have like the subjective exam, and just the initial evaluation is all module 1. And then module 2 is the pelvis, where we talk about the pelvic biomechanics and how that pertains to the pelvic floor muscles. Then module 3, whoop, whoop, foot and ankle. That's my favorite module of the whole course. Then we have module 4, which is rib cage and thorax. That one's tied with pelvis, I think, for my second favorite. And then in module 5, we're going to go over holistic and non-biomechanical stuff because that matters. Like if we're only looking at biomechanics, we're not looking at the full picture and we're not helping our patients to their fullest potential. And then number 6 is not a module, but exercise and manual therapy is sprinkled throughout every module. And you get this huge library, this resource library of 70 something videos to continue to refer back to literally forever. I don't take it away from you. Okay, it's for PTs, OTs, movement professionals, rehab chiros, who work with women with pelvic floor dysfunction. Specifically, it's going to help the most with leaking, prolapse, and pelvic pain. It's perfect for you if you're looking for a framework you can follow to get to the root cause of why your patient's pelvic floor isn't working optimally. If you're sick of traditional pelvic floor education that teaches pelvic floor strengthening for leaking and prolapse, but pelvic floor relaxation for pain and constipation, newsflash, it's not that simple. It's perfect for you if you tend to use exercises like clamshells, bird dogs, because you know that the core and hips are important for pelvic floor function, but your clients, they're still not getting to that 100%. If you're bored with teaching your patients to squeeze their pelvic floor during lifts, and honestly, like, there must be a way to move beyond that sort of symptom management. And it's perfect for you if you're curious and excited about what I taught you about the foot, which I hope you are because this is my favorite topic, and how it impacts the pelvic floor. and you're ready to dive deep into that concept and more so you can get your patients and clients real results that actually last. Okay. So, just a couple quick little testimonials. Hopefully, y'all can hear them.
Hey guys, my name is Audra and I'm a pelvic health occupational therapist. And I just want to say that I highly recommend if you are a physical therapist, an occupational therapist, or any other clinician that's treating the pelvic floor, that you need to take How to Treat the Pelvic Floor Without Kegels. Dr. Becky Allen is truly amazing, and she helped me better understand the pelvic floor at a deeper level to be able to better help my clients. I had a pretty good understanding of the foundations of the pelvic floor, but this course took an even deeper dove into how we can look at the whole body to better address the pelvic floor and why doing things like Kegels are just not beneficial for our clients. I love this course because it helped me be able to build a bridge of my understanding of how the pelvic floor connects to things like your shoulders and your ribs and your feet and your ankles, and just all the things that I feel like a lot of people don't realize are big connections to our pelvic floor.
Love you, Audra.
Hey there, I'm Angela Mosey, and I'm a pre and postnatal corrective exercise trainer. I recently took Dr. Becky's How to Treat the Pelvic Floor Without Kegels course, and I absolutely love it. I currently work with well over 1,300 women in my courses, women who used to pee their pants. And because of the strategies that Dr. Becky talks about inside of her course and lots of the exercises that she shares with us and the education to help us educate ourselves so that we can educate our clients, has really helped me to impact more than just my local community, but women all over the world to break through their barriers of leaking without giving them a single Kegel. And I think that's what makes this program so specific, is that so many women are being told to just do Kegels, but we don't know what else to do. And Dr. Becky's course tells you exactly what to do to help your clients to break through those barriers of leaking without doing isolated Kegels. We need to break the chain or break that common myth that Kegels are the answer to treating the pelvic floor. And we need to break out of it and start incorporating exercises, specifically the ones that Dr. Becky teaches inside her course. I'm forever thankful for all of the things that Dr. Becky has shared inside her course and with her coaching. And I am so overjoyed to be able to share that with my clients and help them break through barriers so that they no longer pee their pants accidentally or embarrassingly when they sneeze or when they jump on trampolines.
Yes, Angela. Okay, last one.
I absolutely loved your course. It really helped me like synthesize the lower extremity, because that for sure was my weakest point. And it's just thank you so much. And the videos, and because I'm a visual learner, it just put everything together so well. So I really enjoyed your class. I think you made me better.
So precious. Okay. So just as a thank you for all of you guys being here and hanging with me for this hour and a half. We are about to get to your questions, so I'll stay past 5:30 or whatever time it is for you, so don't worry about that. But as a thank you, I want to offer you guys a discount for my course. So there's two tracks. We have a self-paced and a VIP. The self-paced is going to be the one that most people will do. This is for those who prefer to learn at their own pace and implement concepts independently. You get full access to the modules and videos and the templates. You get the course workbook to follow along. You get my initial evaluation template for easy implementation. You get that video library with all the assessments and exercises. And you get to go at your own pace and revisit the materials anytime for a lifetime. I don't take it away. The VIP track is going to be for those who want that real-time feedback, that group support, and then the deeper case discussions. You get everything from that self-paced track. Plus, you're going to get the weekly live group coaching calls to break down the real cases. You're going to get a private Slack group for support for the modules and between modules for your questions, to share our wins with our patients. And it's going to be a small group setting. So I'm limiting this to 10 for personalized guidance. So I'm giving you guys a discount through Monday if you're interested. So the self-paced, you're going to get $100 off through Monday, and the VIP, you guys get $200 off. And again, there's only 10 spots of that one. So if you're really thinking about it, claim it. Or if you want to email me more questions about the VIP, that's totally fine. The VIP, real quick, these are for the people who really want to dive deeper into the course material and do real-time case applications with my help to kind of go like apply it to your specific patients. This is for the person who learns best when you can ask questions and get direct feedback. You love the energy of a group, hearing different perspectives, troubleshooting challenges together, and expanding your clinical thinking. You know that accountability leads to action, and you want the structure to apply what you're learning, honestly. And you want to connect with other like-minded PTs and OTs who are committed to changing the game in pelvic health. Again, this one is capped at 10. The self-paced is uncapped. So I can have a million people in there, but I capped this at 10 to kind of keep it intimate enough. So with the course, my promise to you is that you're going to learn a new way to assess the pelvic floor. You're going to be able to combine what you find internally with, if you're an internal treating person, you don't have to be to take the course, with what you see in the patient's movement patterns. You're going to learn to view pelvic floor dysfunction through a holistic lens that allows you to zoom out and view the patient as a whole. You're going to receive actionable techniques and interventions to take back to your patients after each and every module. And at the end of the course, you're going to view the pelvis and the pelvic floor as a synergistic piece of the human body that's integrated in how we breathe, how we move, and you're going to know how to treat the pelvic floor without Kegels. It's the best. It's the best. Okay, the investment for the self-paced, again, you guys get $100 off, is $597 through Monday. You're going to get the 5 modules, super digestible. You can implement what you learned immediately. You get that course workbook, you get the initial eval template, and you get my ever popular 70 plus video library for quick access to all that stuff. For the VIPs, again, this is for 10 of you guys. This is $1597 through Monday, so that's not $200 off. You get everything in the self-paced course, plus you get weekly live group coaching calls, and that way you can leave feeling confident in applying the strategies. You get access to a private group Slack to ask questions. You get to share your wins and keep the momentum going. So we start March 31st. The new modules drop each Monday morning. You go through those on your own, and then if you're in the VIP, we start meeting those on April 9th because we talk about the previous week's module and apply that to your patients. And those are Wednesdays at 11 Central Time from April 9th through the 7th is going to be our last one. So check your email. You already got it there with the discount code. Please join us. I would love nothing more than to have more of you guys learning this material and changing the game with me. So thank you guys so much for being here. Like I said, I'll stay past 5:30 because I went a little longer than I planned to. I plan to leave about 20 minutes for questions, so I'll stay. Madison, if you can work on unmuting people, hopefully we can get you unmuted, and then I will take some questions if you have any. Let's see. People, do y'all feel like you're able to unmute yourselves? There we go.
Becky, can you hear me?
Yes, I can.
Hi, my name's Karen. I'm a pelvic floor therapist in Cleveland. I loved your lecture. My question is, so you talked a lot about pronation. Do you have any good strategies for supination? People who are over, like either stuck in supin, well, I know that puts them into pronation, but getting them, my very flat-footed patients. Sorry, that's where I'm going with this. And
Yeah.
I'm getting over a cold, so my voice keeps going out.
Oh, yeah, no, that's a wonderful question. So short answer is absolutely. I also always like to point out that our overpronating patients, I teach you in my course, I go a lot deeper on sometimes people look like they're overpronating. They're actually just kind of externally rotating the lower half of their leg and kind of getting what I call this fake pronation. So they're kind of falling into this fake pronation because they actually lack the range of motion. So to our eye, it looks like they're an overpronator, but then when we do the navicular drop test or we do some of these other functional movement assessments, we actually see that they tend to live more on the outer aspect of their foot and they're just faking it. They're like, their brain is like, oh, well, I need pronation, so I'm just gonna turn my feet out and fall. And so there's a little that's a different patient than a true overpronator. They do exist. And yes, to answer your question, things like strengthening the posterior tibialis is going to be huge for them. strengthen, just arch strengthening in general. But again, I want you to be able to determine, is it true overpronation or is it that fake pronation? And I go into that in my course. Yeah. Does that make sense?
Okay. It does make sense. Thank you.
You're welcome.
Also, I just signed up for your class. That's how committed I am.
Stop. Oh my gosh, you get a gold star, Karen.
I hope I get an Alta shoe is what I really want.
Oh my gosh, I love it. That gives you an extra entry.
Yes.
I love that so much. You're gonna love it.
I can't wait. I'm an orthotherapist at heart, I love the pelvic floor as well, but I'm excited to brush up on some of this.
Oh, yes. No, if honestly, my ortho therapist like just nerd out in this course because it's very ortho. It's very ortho based, but it kind of gives you this lens to start thinking about, we talk about pelvic floor symptoms, but honestly, this fixes low back pain, hip pain, like this line of
Right.
thinking. So
Thank you.
thank you. Who else?
There are quite a few questions in the chat.
Okay. Let's see. Let me just.
Becky, I put those in the Google Doc if you want to open that up. I resent you the link.
You're the best. Yep. Yep. Okay. Let me just look at that. Did you email it to me, Madison?
I just sent it in the chat, so it's easy for you to
Perfect.
grab.
Okay. What a great. The question is, how do I find will you send it one more time? I'm just kidding, I see it. I lied. Okay. Okay, so here's some of the chat questions. So why does the pelvic floor ascend when it lengthens? Okay, this is a great question, a great concept to understand. So let me do my best to explain this without taking 5 hours. No, I'm just kidding. So the pelvic floor ascends when it lengthens because of the bony pelvis and what happens at the outlet, okay? That is different than me thinking in my head, squeeze and lift my pelvic floor. Those are separate things. So if I think do a Kegel, squeeze and lift, that is not eccentric length and ascension, okay? That's concentric ascension. Okay, so what I'm talking about is if we want to restore the pelvic floor's ability to work automatically and responsively, we have to restore this whole chain IR to allow this boing, boing. So that's like, it's an eccentric ascension. So hopefully that clears that up a little bit, but it's because it's different than concentric squeeze and lift Kegel. Okay, seems like this velocity is gold for SUI, which is a force issue where maybe Kegels can be helpful for urge urinary incontinence. In addition to all our lifestyle diet review too, would love your thoughts on this. Okay, so urge urinary incontinence, this is a great question. So, we can use pelvic floor contractions, Kegels to do bladder retraining, right? That will quiet the urge. You are exactly right that what I'm talking about is this force absorption pressure management stuff. So slightly different concepts. However, we still need to get to the root cause of why are they having urge? Why are they having urgency and why are they having incontinence with the urges, right? And so that could be a whole host of things, right? It could be dietary, it could be nervous system, could be biomechanical, because it could be that the pelvic floor tension is so much around the bladder and it's irritating it, right? Like there's a lot of things. So we do want to do a thorough subjective and a thorough exam to figure out where the urge is coming from. But if it is coming from like a pelvic floor that's irritating it, that's where a lot of this internal rotation and I didn't really use this terminology or talk a ton about this, but this posterior pelvic floor expansion concept can be a game changer for urgency and for urge incontinence because it creates space in the pelvis where the bladder is. So different, yet there's some relation there. That's a great question. Okay, let's see. Is the band and the exercises at an angle or straight ahead? Okay, so this is for the band. It was straight ahead. That's a good question. So it's like if the band is wrapped around my shoulders and if it's coming from this side, it's literally straight ahead of me. And I'm like rotating into it. Okay, so that's a great question. It's basically pulling me and it's trying to turn me this way, but I'm not letting it. So it's straight ahead. That's a good question. If you angle it across, that would be even harder, but um, let's see. Why is the band resisting IR? Great question, because we talked about how we want IR, right? So those exercises with the band resisting us going into that internal rotation is teaching the control aspect of, remember when I talked about like from a foot perspective, we need that pronation range of motion, but we also need to control it so we don't fall too much into this pronation, okay? Same at the pelvis. We need this femoral IR, range of motion, but we don't want too much of this collapse of the pelvis collapsing on top of it. We need some because we need that ilium to do a little bit of that IR for that pelvic floor, but we don't want too much because then that's when we get, we need the Goldilocks, right? We need it just the right amount. So the band is teaching, it's kind of using that neural re-ed to control yourself in space and helping the pelvis kind of find the stability on top of the fem head. Just reading through these questions. Are all these things you assess? Oh, are all these things you assess from the get-go or more if a patient is not progressing? From day one. I look at all this on day one. In my course, this is my method I teach you. So super, super, super easy, simple, quick functional movement assessments that you're going to get to go through. Takes me, I don't know, 20 minutes. I have a 90-minute eval though too, so that helps me. But you go through all of them on day one. And the thing I love about the functional movement assessments is you get to look at like the hip and the pelvis and the foot and the ankle and the rib cage all in the same movements. So like we'll break them down in every module, but they're all the same, few assessments. So it's really cool. Okay. Is this only for female pelvic floor? I treat a lot of men. So the function is the same in men. Like it's all biomechanics, right? Men are going to have the same thing happening at the pelvic floor with whole chain IR as women will. I don't personally treat males, but what I know about males from my colleagues is that their posterior pelvic floor is tight, okay? Like it is like everything back here is just like, because they're like butt clenchers. So the pelvic floor back here, their iliums are externally rotated and everything is like short and tight. So the men need this posterior length and this ilium IR to open up this posterior chain, usually. So that's a great question. I will say I have a coaching client who's developing a male treatment course, and she's the best in the game with it. So stay tuned. I'll let you know when that's ready. Let's see. Oh, why are ultras recommended? What's so special about them? For me, they're my favorite because they are a running/walking shoe. They also have a cross-training shoe that is wide toe box and zero drop. So this is the first shoe personally that I've tested that like, and I'm not a runner, like I'll do like a run walk, but I like to go on a lot of walks. And this is the first shoe I've tested that didn't make my feet feel like they were in feet jail. And that I could feel my midfoot being able to go into that pronation with every step I took. So that's why I love them. And I get no kickback. Y'all, they don't do affiliate anything. And I'm over here shouting them from the rooftop. I'm just like, buy ultras to like everyone I know. And like, I'm like, can I please just have a code? But that's why I recommend them. And that's what's so special about them. Okay, let's see. Do you have names of PTs who have taken my course? Oh, so many people have asked this. I'm going to make a directory. I need to email everyone. I have my past student list. There's 300 something of them on there. I need to email them and ask if they're okay and of me creating a directory because that's a great idea so that people can know who's taken my course. I'm so interested in your course. Do you offer a student discount? Oh my gosh, email me. Yes, love the students. Is the course eligible CEUs? Okay, great question. Yes, and it's not in every single state. I have a list. If you are like if you're someone who is like it's like make or break if you have CEUs or not, email me and I can tell you what states. It's most states. It's whatever states have reciprocity, whatever that word is, with Texas. So you can even Google that for like, and this is for PTs, OTs. It's not that I hate your guts. I love your guts. It's that I have like, I'm still in the process of trying to learn how to get the PT stuff translated over to the OT side. So this is specific for PTs right now. But yeah, if you want to look up what states for PTs have reciprocity, I think is the word, with Texas for Con Ed credits for courses, it'll tell you. Or you can always email me too if you're like, is my state covered? And I'll be like, probably. So it's most states. Okay, so those, did any other questions come up? That was the last on my list. If any, I mean, like I said, I'm happy to stay a little bit longer if you guys have questions. Kristen, if you stay on track with the course, how many weeks? Okay, great question. So if you stay on track with it, it'll be 5 to 6 weeks because it's 5 modules. And the modules themselves are about an hour. Some are a little bit longer than an hour. Some are like 50 minutes. And then you have all the exercises that you can go watch and start implementing with your patients that week. But it's pretty easy to kind of digest, like watch the module on, when one sit down and then kind of digest it through the week and practice the stuff. Is there a replay? Absolutely. I just got to upload it. I'll email it out probably tomorrow to you guys. Let's see. How does a tendency to toe in and femoral anteversion play into this? Okay, yeah. So femoral anteversion and then like toeing in. Obviously, there can be some bony, different anatomical differences, right? So like if someone has those bony changes at the acetabulum and at the femoral head and stuff that turns, like that causes them to kind of like turn in and stuff like that, that's one thing. Honestly, like I have a daughter, she toes in, and I'm literally I'm like, what can I do? I'm like, is this your hip? Is this like your pelvic floor? But it just made me think of my daughter. I don't know, that was random. But how does it play into this? Honestly, these are people who they're compensating. If I'm talking the non-bony change people, in my opinion, they're compensating. They're trying to kind of get their brain is trying to get their weight shifted to where they're feeling a little bit more stable in space and where they're getting kind of the biomechanical like chain reaction that it's like looking for. But these people, they're gonna have kind of this over lengthen. They're gonna need more like, yes, eccentric control, but also probably some concentric control of the external rotators as well. That's a great question. Ooh, yeah. Okay, Sheila. So if we're a trainer, how do we handle the pelvic floor PT? Yes. You're gonna message Colette. She is a queen at this. No. Here's what I've kind of advised some coaches and trainers to do, because as a PT who instructs my patients on certain things for their workouts, right? Like I wouldn't necessarily love it if I heard that a coach or trainer was saying, "Oh, like your PT said to do that." Like don't do that, right? Like that would probably make me mad. So don't do that. I would encourage you to talk to the therapist and no worries about the typos. I would encourage you to talk to the therapist, maybe set up a call and get curious and just ask like, hey, like I would love to understand more about why you told my client not to do this or to do this way. I'd love to understand because there's always a chance that they have a good reason, and maybe you're gonna be like, oh, okay, like that makes sense. Or maybe their reason sucks, and you can be like, oh, well, here's the way I see it. Here's my understanding, and maybe you actually get to educate them in a respectful like way, and hopefully they don't think they're high and mighty just because they're a PT or whatever. So that's kind of what Colette has done. That's how she's changed the game over in the UK is she's doing workshops. She's inviting physios to them. She's setting up meetings with her clients' physios and asking questions. And she's doing all that. So that's what I would suggest. Anything else? Let's see. Ooh, does my course talk about the fascia? Is ball rolling for the foot good for the pelvic floor? Yes and yes. So I do touch on the anatomy of like the fascial trains that go through. And there's like, different, there's like deep front line and there's like lateral line and all this stuff that I do touch on in the course. And so yes, that's why the ball rolling can be very helpful for the pelvic floor because there is that anatomical fascial connection. It also is helpful because of when we roll and like roll the ball on the bottom of our foot, the area of our brain that lights up when we do foot stuff is right next door to the area of our brain that lights up, sounds weird, but with our genitals. So it's called your homunculus, basically. It's they're very connected. They're next door neighbors in your brain. So when you do foot stuff, aka rolling the ball, it actually helps your brain to form better connections with the area around the genitals too. Maybe that's why people have foot fetishes. I don't know. That's weird. I don't have that. I just like the foot for helping the pelvic floor. Uh, but yes, it also helps because of that live fascia connection. And it helps because it improves the midfoot's ability to pronate because you loosen up all that stuff on the bottom of the midfoot, and now your midfoot can move better, and now pelvic floor works better. Yes, Madison, love the homunculus. Me too. Yeah, when I roll my foot, I feel it in my pelvic floor, right? Right? That's your homunculus. That's your brain being like, oh, your foot's lighting up and it's kind of lighting up the pelvic floor too. It's a good thing. Anything else? This is great. I love these questions. Going once. Going twice. You guys, for real, y'all can
Hey,
all.
Becky.
Oh, yeah,
Oh,
yeah, go ahead.
sorry. I do have a quick question. I am a pediatric focused therapist, and I'm thinking a ton about foot posture in these kiddos that are wearing devices at young ages, and just wondering if you've had very many people take the class and then that carryover for these, like the little ones that are slow to gain continence and having issues. We have so much of that in our pediatric clinic, and I'm just really curious as if you've had much of that carryover.
Yeah, I've definitely had pediatric therapists take it. You're gonna have to use your creative thinking, right? And kind of look past all the talk about female stress incontinence and prolapse and stuff. And
Sure.
if you can kind of think through the biomechanics and think about how can I help these kiddos honestly load their midfoot and learn to, not rely so much on like our pregos do, shift forward and like walk like this or not
Correct.
rely, stuff like that these little kiddos do when they lack stability. If you can get creative and think about how can I put them in positions to where they're loading that midfoot and getting a little bit more like, hopefully you can see me back here. Maybe I can't see, but kind of getting them over that midfoot region
Right.
would
Right.
be huge. And yeah, I've had pediatric therapists take my course, and
Okay.
yeah, I can't say I can pull any testimonials right this second of they're like, this changed the game for my pediatric patients, but they've told me they loved the course. So
Absolutely. Yeah. Well, as a PT, there's always stuff to gain and that you
that's true.
gain, whether personal or not, even in pediatric practice. But I was thinking a lot as you're talking about these kiddos that start in orthotics for so long that their foot is so rigid
Yeah.
that then down the road, getting them out of the orthotic, what can we do and whatnot. So thanks.
You're
Yeah.
so welcome. You're so welcome.
Appreciate your time. Yeah. Thank you.
Sure. Okay, I had a patient yes, I had a patient who canceled his eval because his pelvic pain went away. The change, new boots. Uh-huh. Yeah. Probably got some more room in his toes. Maybe he went to square toe instead of pointed toe. No, I'm just kidding. But for real. Let's see. How would you adapt for a patient that has bunions or rigid big toes? Oh my gosh, I would mow the heck out of that stuff. I try so hard to not let my patients get bunion surgery, and instead I really, really work on like great toe, like abduction, midfoot loading, a lot of foot manual therapy, a lot of homework for manual stuff and exercise at home. And it's honestly the same. Like it's the same stuff. People can just be more genetically predisposed to have bunions, but you can still, the body's amazing. You can still make effective change and symptom change on these people. Thoughts on a middle-aged human changing out of orthotics after years. Wait for strengthening of the foot. Oh, switch shoes slowly. Okay. Great question. Yes. Whenever I take my clients and patients out of orthotics that have worn them forever and ever and ever, I tend to wean them off of the orthotic, like let's wear it less and less time. And I usually do that in their same shoe that they're used to. Then once they're out of the orthotic in their same shoe, then I tend to try and wean them out of the shoe and get them into, honestly, ultras, because ultras are a good kind of transition shoe. Some of them have the 4 millimeter drop, some are 0, some have slightly more support, some have less support. So you can kind of pick, like, let's start with the more supportive shoe and work your way down to as least support as they can. And you're going to have to support them with exercises through there for their foot to build the strength as they go. But yeah, I would definitely wean. Yes, Ultra better than Vivo or 0 to transition. Yes, Vivo and Zeros are barefoot shoes, in case you guys don't know. I love them. I have both. My kids have 0 shoes and Vivo shoes, actually. And I weight train. I do my deadlifts. I like doing my deadlifts and my Vivos. But yeah, those would be a stark change from someone who's lived in orthotics his whole life. Anything else? And you guys, what I was gonna say earlier is if y'all don't have any more live questions, my email's always open. You can email me. I'm always in my Instagram DMs. Don't be a stranger. But these were all really, really good questions. So who gets the ultra? That's a great question. Madison took a screenshot of all you guys that are still here, and we're gonna do a random drawing. So I'll email you. I'll email you guys. If it's not tonight, it'll be tomorrow whenever I get the recording, but I'll let y'all know for sure. Thank you guys. Y'all were awesome. Y'all were a great group. Yay! You guys are the best. Have a great day. Oh my gosh. Awesome. You guys are so nice. All right. Madison, thank you for your help.
Of course. So much. I want to sign up for the course now. I want to go.
Do it. Do it. I'll give you a student discount.
All right. I'll text you.
Yes. Okay.
And I'll send you over everyone who's still here.
Amazing. All righty. Well, I'm going to go ahead and close us out.
Bye.
Well, good night, everyone.